surveillance, an abstract looked at the role of upper tract imaging for high-grade non-invasive surveillance. They looked at about 400 scans and found that only 4 or 1% were diagnosed with an upper tract cancer. Interestingly, all had had low-grade TA bladder cancer previously. The number needed to screen was 115 to detect a single upper tract cancer, with the take-home that upper tract surveillance may have limited benefits in high-grade non-muscle invasive bladder cancer surveillance. Another study looked at over 2,000 cystectomy patients, and they developed a risk-adapted protocol for surveillance based on stage, age, and comorbidity, and this risk-based strategy may streamline cost and efficacy in the future. With regard to urine biomarkers, CX Bladder Resolve was evaluated. This is a test to identify and stratify high-grade or late-stage disease among hematuria patients. It accurately identified 95% of high-grade urothelial cancer and had an equally high negative predictive value of 99% for low-risk patients. Another study looked at CK20 and IGF-2 expression in conjunction with urine cytology. They found that increased sensitivity to 93%. It also slightly reduced specificity to 84% in their validation cohort. So several urine biomarkers may have utility in risk stratifying our bladder cancer patients. Several abstracts looked at the theme of androgen receptor as it relates to bladder cancer a variety of ways. The first compared men with and without ADT and found that ADT was an independent risk factor for intravesical recurrence. Another study looked at a cohort of nearly 43,000 patients with BPH using finasteride at 87-month follow-up and found that finasteride was protective of bladder cancer risk in Caucasians and Hispanics, but not so in African Americans. And finally, androgen receptor activity as it relates to treatment. One abstract found that androgen receptor activity correlated with sensitivity to radiotherapy in bladder cancer, and another looked at receptor activity that modulated direct cytotoxicity of BCG in bladder cancer cells. So the take-home point here is that emerging evidence exists that androgen receptor activity may be related to recurrence and treatment in bladder cancer. A late-breaking abstract this year focused on blue light flexible cystoscopy. This is a prospective multi-center study for patients with non-muscle invasive bladder cancer. They looked at patients undergoing surveillance with blue light flexible cystoscopy, and a subset of those went on to TURBT if that was suspicious. They found that blue light flexible cystoscopy improved detection of recurrent bladder cancer by 21%, and they also noted that repeat use of blue light cysto with CystView is safe, with a take-home that blue light flexible cystoscopy should be considered for patients in surveillance of bladder cancer recurrence. So moving on to intravesical treatment, the results of the SWOG S0337 study were presented. This was a phase 3 randomized controlled trial of post-TURBT intravesical gemcitabine versus saline for recurrent low-grade disease. Gemcitabine reduced recurrence of low-grade non-muscle invasive bladder cancer by 47%, but did not for high-grade disease. They found it was safe, well-tolerated, with no difference in adverse events, with a take-home that intravesical gemcitabine is a new standard for suspected low-grade non-muscle invasive bladder cancer. Another study looked at chemoablation of non-muscle invasive bladder cancer with Vesagel, which is a formulation of mitomycin C in a hydrogel. They looked at 2 concentrations of Vesagel compared to mitomycin C and saline as an alternative to TURBT. They found excellent complete response rates, 86% in the higher concentration group, larger tumors particularly so, and no difference in recurrence-free survival. So Vesagel has chemoablative potential as an alternative to TUR in our bladder cancer patients and select patients. With regard to cancer vaccines with BCG, there was a randomized controlled trial presented, BCG versus BCG plus Panvac. It's a therapeutic cancer vaccine. It showed higher rate of all immunologic responses with the vaccine. Another abstract highlighted outcomes of intradermal BCG priming prior to intravesical induction for high-risk non-muscle invasive bladder cancer. It showed that priming improved T-cell mediated cytotoxicity and increased urinary IL-2 and IL-8. These results actually inform the now activated PRIME trial. It's comparing Tokyo strain, and they're also going to be looking at PRIME versus BCG only. The take-home here is that combining BCG with vaccines such as Panvac and intradermal priming may have a role in increasing efficacy of BCG immunotherapy for high-risk disease.